gentlemen. Ladies and gentlemen, because you have already grown up. Very big. All doctors. Later the day, you can become my bosses also. Today the class is very, very interesting. I am very keen that it should be recorded. Why? It will be beneficial to look at some people who will be watching. The idea is to save a life. At least in your lifetime, save somebody's life. I assure you, if you listen to my talk, just few minutes, pay attention. Forget about movies, forget about your girlfriend, forget about your boyfriend. Listen to my talk. Next few minutes. Forget about allergy, forget about your punishment. And think and watch me and listen to me carefully. I assure you, you can resuscitate the dead person. Guarantee. You can imagine, as a doctor, you might be giving medicine, treatment, surgery, suggestion, prescription, or some consultation. The patient may improve, may not improve. Chances are they may improve. Resuscitating a dead patient, can it be equated with the previous one? No. This is the ultimate. And the satisfaction, if you can resuscitate successfully even one, it's worth living, worth becoming a doctor, worth making so much effort, spending so much of money for the certification. It's really worth it. So pay attention. So cardiac arrest, you must have heard the phrase cardiac arrest. Heart suddenly stops, respiration is no more. Or sometimes respirations are there. When respiration is there, cardiac is definitely there. Cardiac can stop, but sometimes respirations are still there. That time what you have to do is excellent cardiac massage. Same thing, the vice versa. And if heart is there and there are no respiration, you don't have to do cardiac massage, just give respiration, patient will survive. Similarly, if somebody is standing for long, suddenly falls unconscious because of vasovagal shock, don't start giving cardiopulmonary resuscitation. It's foolishness, you will kill the patient. Don't do that. First, you auscultate with your stethoscope if you have it. How many have the stethoscope right now? Raise your hand. Yes. As a doctor, please carry a stethoscope most of the time. It will help. Because palpatory may fail. Putting your ears to the heart may fail. And responses may be giving a wrong judgment. But auscultation will never fail. Easiest way to palpate the carotid pulse. Okay? Feel your carotid pulse. It's natural. Don't feel both sides, only one side carotid. Please feel your carotid. Are you able to feel it? Lifting of the finger. That is there, you are still living. I hope you are all living. Okay. Sometimes it may be difficult in the chubby people and all. You can do antecubitus region for brachial pulse or in the femoral pulse. All the three are not there. Don't keep on palpating for minutes together. Every 10 seconds are given for making a judgment whether patient is alive or gone. Cardiac arrest has taken place. It will be very fast. Within 10 seconds, you have to make up your mind whether the patient is alive or dead. Okay, now you have made up your mind. There is no response. Hello, 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 no response. And heart is not there. You can see the chest, is it lifting or not? No respiratory effort. You can make out some movement of chest is not there. Or sometimes it may be patient, pulse may not be palpable, but patient will be slightly gasping. That is also cardiac arrest. Don't think that he will wake up and start running. You have to do CPR immediately. Cardiopulmonary resuscitation. Now, I'll be telling basic life support as well as advanced cardiac life support. What is the difference between the two? Basic life support is external cardiac massage and giving mouth-to-mouth breathing, or sometimes AED, automated external defibrillation. Fine. That defibrillates the ventricular fibrillation. AED, automated external defibrillation. You don't have to do anything, just put a pad here, put a pad here and put on the AED, and everything will be visible and it will be telling you what is to be done, what is the diagnosis, whether you have to give cardiac shock or not. Cardiac shock suddenly will not be given unless you press a button. And how much to be given also, it will decide. It's all software generated. Okay. So you just have to press the button when shock is to be given. And when shock is being given, you have to clear it, otherwise you will be shocked. You will get ventricular fibrillation. Suddenly, if somebody touches you with the electricity, what you get? Ventricular fibrillation, that's how you die, electric shock. Okay? Not dancing with the music or with the electricity. You have to have a shock, it's cardiac arrest because of ventricular fibrillation. How to prevent it? Now, once ventricular fibrillation takes place, the only treatment is not external cardiac massage. It has to be defibrillation. If heart is palpitating, fibrillating like it, and the ECG monitor if at all is already connected, you're showing various wavy things. That is ventricular fibrillation. You have to do electric shock. And the best part of it, earliest you give defibrillation, the chances of survival is high. 10 seconds if you are late. If you are 1 minute late to give defibrillation after cardiac event, 10% chances of resuscitating goes off. This was a question to MD anesthesiology exam students. Some of them couldn't answer. I tell you, very simple. You have got defibrillated lately. But when I call you, operation code blue, you have come to the patient after 10 minutes and you have given the shock. Immediately after arrival, within 10 minutes, you have given the shock. What is the chances of its survival? Perfectly you have given shock. Within 10 minutes, you have come and given. What are the chances of survival? Somebody said 50%, somebody said 10%, somebody said 80%. The answer is 0. Not a single person will survive. Why? After 10 minutes, you have arrived. Each minute of delay, it will fall by 10%. So 10 minutes means 100% chances of revivability, resuscitation goes off. So there is no point in giving electric shock or this thing, defibrillation after 10 minutes. So now you know how important it is to attend the patient at the earliest. Okay. 80% of cardiac arrest is because of ventricular fibrillation or ventricular tachycardia. Then the remaining 20% is because of ventricular asystole or pulseless electrical activity. We call it PEA. These questions will be asked in your Viva as well as in NEET exams for me. 100%. Same, majority of the questions will be coming from this topic only because they want to see how alert and how good a doctor you are to safeguard somebody patient in an emergency. Cool, you have got a lot of time, you can consult 10 people, you can Google it and give. That is not doctor. Without Googling, without consultation, you have to act. That time you don't have to call somebody. Yes, you may have to call somebody for help for procuring the AED. Immediately. If you are abroad, US, you have to call the number 911. If you are in India, there's a number 108. For God's sake, remember that. 108, emergency. And India, incidentally, it is very, very functional and really active. You just dial 108. They will definitely attend. An emergency ambulance will be sent or come. In that, resuscitation equipment will be there. But till that time, you'll have to do resuscitation. Don't keep on waiting for the ambulance to arrive and do that later. Keep on doing. That is the time you have to do CPR. Okay. Cardiopulmonary resuscitation is very, very simple, provided you know. You have to give pressure on the lower part of the sternum. This is lower part of the rib. This is the sternum. This is from its here side and its ends here. The xiphoid cartilage is the lower part. Upper part is manubrium sternum. Lower 1/3 you have to press. Don't go very low because there will be xiphoid cartilage that gets breaks, its cartilage got disconnected. Tuck. You can hear the sound also when you are resuscitating and you are done a mistake, putting your heel of the hand much slow and you are pressing the chest. Tuck. There is a sound. That means you have fractured the defied cartilage. That's a wrong move. So you have to at least put two fingers above the lower body. Start pressing. Okay? So the defied cartilage is avoided and breaking. That's very important. Now, how long? You have to give, in 1 minute, you have got 60 seconds. You have to give 100 to 120 compressions in 1 minute. That means in 1 second, like when I call 101, it becomes 1 second. In this period, you have to press twice. Okay? And when you press down, you have to make sure that it should be recoil. Bring it back. Bring it back also. So that just get expansion time. So whatever the vein blood has gone through veins, it comes back to the heart. Why cardiac compression is so essential and so fast issue? Earlier we used to have ABC for resuscitation: airway, breathing, and compression. In 2010, American Heart Association has converted ABC of resuscitation to CAB, CAB. Please write down CAB. CAB stands for compressions first, then airway, then breathing. The priority has gone to compressions first rather than correcting the airway and the breathing. Why the sudden change? They have realized if they start compressing, the resuscitation chances much higher compared to airway and breathing first. So it's instead of ABC now it will become compression. Okay. Now, how many times I said? 100 to 120 per minute. You don't have to think this 101 also may be wrong because it's too fast sometimes. So you can judge in 1 minute how many seconds you can feel it. You have seen, in 1 minute how much time it elapsed. In that you have to complete at least 100 compressions. And what the depth should be? It should be minimum 2 inches in an adult. If it is a child or lower, it should be equal 1 to 1.5 inches. 1 inch has 2.5 centimeters. That's how you can understand. So minimum 5 to 6 centimeter depth you should press. The lower 1/3 of the chest. How? First you have to put one hand heel onto the lower third of the sternum. And the other hand, with that you don't press. No, you have to put another hand and clasp your finger. Interlace the fingers and then when you pressing, this is active and the lower one is passive. Okay, I'll show you. I'll show demonstration. I'll show you the demonstration how we have to press, and you can also keep on practicing even after that. It's very, very important how you compress. Don't worry about putting endotracheal tube and all. Without that also you can save the patient. If you are not given ventilation also, still patient can survive. At least compression only life support. That is called calls. At least you keep on compressing till the emergency team arrives. 108 guy comes and takes over. Till then keep on compressing. At the rate of 100 compression to 120 per minute. And breaths. If you are daredevil, now during COVID, we never used to advise you to do walk-to-walk. 2020 to 2022, nobody has asked. Now, American Heart Association gives guidelines every 5 years. The last guideline, the PPT which I am showing is latest guideline, 2020 guideline. 2025 will come this year, every 5 years. It is yet to come. Once it comes, I will show you. Okay. So what are the guidelines? What you have to do and how? Breaths, you have to give single breath in every 6 seconds. So in 1 minute, how many seconds you have? 6. So every 6 seconds you have given breath, mouth to mouth breathing. Every 6 seconds. How many will be? 10. 10 per minute. Don't increase more than 10 and don't decrease less than 10. Even when you are compressing, don't decrease the compression less than 4 centimeters and don't increase the compression more than 6 centimeters. It be counterproductive. Okay, and trying to help somebody keep on ventilating, or with the back mask you are doing, keep on ventilating, it will be counterproductive. So no use rather than worsening the situation. So give only 10 breaths per minute. Even if you are intubated, you have to give that rate. Intubated means put an endotracheal tube in the trachea. Okay, now I am going to show you how it has to be done. Done. Uske baad, after that, what you have to do? Keep on doing. And once the AED comes, takes over the priority. As I said, 80% of cases is ventricular fibrillation. You have just taken a chance. Hopefully, it is cardiac assist, and you are compressing. Had it been ventricular fibrillation, all this compression will not be any of use. If you are doing a compression and the patient survives, that means it was cardiac asystole or plus electrical activity. Chances are less. Incidentally, in the hospital, if somebody has cardiac arrest, it is 90 to 100% cause is asystole or pulseless electrical activity. If a person has cardiac arrest at home or on a road or outside hospital, 90 to 100% chances it is ventricular fibrillation. So how important is you should know? Suppose somebody has fallen suddenly on a roadside and you are there as a doctor, you know how to resuscitate. Don't suddenly jump to help him. First see, is it safe area to resuscitate him? Suppose the patient has fallen in the middle of the road. Don't start as a big savior and start resuscitating in the middle of the road. Somebody will crush you in the middle of the road. Both of you will die. Don't do that. Why I am saying? Bring the patient to a safer place. I'll take somebody's help, or you are good enough to lift somebody, I'm sure. At your age, I used to lift 2-3 people. I was in army. So that's a different thing. So, at your age, actually, you should be able to lift one patient, take to a safer place and start resuscitating. Sincerely. Now, once you are putting the patient on the either a bed or this or on the normal soil, should be hard surface. Like even if you are put in a cot, if there is a foam thing, it's of no use, zero. It should be firm. Because when you are compressing, the idea, what is the purpose of compressing the heart? The heart is pressed between the sternum and the vertebral column. The heart is pressed in between the sternum and the vertebral column. And whatever blood is there in the heart, the best part of even after cardiac arrest, for several minutes, oxygenated blood is still there in the circulation. Why do you have to compress? Because oxygen has to reach the vital, most important vital brain at the earliest. Otherwise, oxygen has to reach. How does oxygen reach? Once you breathe, what happens? With the air, it goes into the lungs. Then the diffusion takes place. The oxygen in your breath diffuses into the capillaries from the alveoli. That goes into the circulation. That goes into the heart. Okay. Once heart, it pumps with aorta or thoracic artery downward, upwards, whatever, it goes to the brain. The oxygen in the blood is mixed with the hemoglobin. Hemoglobin carries the oxygen to the area which is vital. Most important is heart and the brain. That has to be given oxygen. Otherwise, ATP production is gone. No energy. No energy means brain will stop working. Heart will stop working. So there will be ischemia, cardiac arrest, and myocardial infarction for the heart, and brain hypoxic. Hypoxic brain damage. Okay. That will take place when you are doing that. And that is irreversible. Once hypoxic damage to the brain has taken place, after that, even if you save the patient, he may be breathing and heart may be functioning, but the brain will not be functioning. He will be vegetative life. Vegetative means he won't respond. What is the purpose? So there is no point saving a patient who is of no use to himself and the society. It's better to leave him die. Now you know how important it is to save a life as early as possible before hypoxic brain damage takes place. Immediately. So now, how you have to resuscitate, as I told you, keep on cardiac massage, and once the AED arrives, put the AED and give the shock. Suppose there is no improvement, keep on repeating the CPR again for 2 minutes and see any improvement has taken. And still there is no improvement, again repeat it. Now, the best part of it, now the role of advanced cardiac life support takes place. What is advanced cardiac life support? The addition of endotracheal tube or giving some medication to resuscitate the heart. Heart has to be resuscitated. How? With medication. The most important drug there is adrenaline. Other name is epinephrine. You have to give 1 milligram every 3 to 5 minutes. Repeat as many times as possible. Every 3 to 5 minutes, as long as you are resuscitating, keep on giving 3 to 5 minutes, 1 milligram of adrenaline. When you see an ampule of adrenaline, it will be written 1 milligram and it will be 1 ml ampule. Preferably, you should dilute with 9 ml of saline so that it becomes 1 in 10,000 solution. Because what you get the ampule is 1 in 1,000. Then why are they giving 1 in 1,000 solution? Why do you in such a hurry? Why it should be diluted? Because if you want, if your IV line is not there, you can still put the drug in the endotracheal tube. In the endotracheal tube, the concentration has to be 1 in 1,000. That is the idea. And you have to give 2.5 times the dose. Instead of 1 milligram, you have to give 2.5 milligram every 3 to 5 ml through endotracheal tube. So that it goes into the heart, into the circulation as early as possible. Through the trachea, it goes into the circulation. Endotracheal tube is passed in the trachea, and the drug which you are putting here will go into the lungs, and there it will be absorbed into circulation. Hope you have understood what is so far. No doubts. Now, adrenaline you have given, no improvement. See whether any induction, any messages is coming from the AED. AED will tell, give a shot, give a shot. You repeat a shot. Okay. Then keep on doing cardiac. No interruption. Cardiac massage interruption should not be. You can do anything, interruption of cardiac massage should not be. You can do resuscitation. Now, if there is, you have got 2 persons helping, 1 more person has come to help you. In adult, the rate of compression ratio is 30:2. Please write down. In NEET, they will be asking what is the ratio of compression to resuscitation. 30:2 in adults. But in a child, when you are resuscitating, when 2 persons are there, the ratio is 15:2. And when you are alone, you have to give 30:2. That means 30 times compression and 2 times a strong mouth-to-mouth breathing. You have to put your lips fixed to the other person's lips and first take a deep breath, expand your lungs, put your mouth on the other person's mouth, blow it in such a way that lungs expand, chest should expand. That means you have done correctly. In a child, when you put a mouth, it will be encircling the nose. So, nose also will be given. In adult, you can pinch the nose so that the entire air is going into the mouth. Otherwise, if you blow through the mouth, half the air is coming out through the nasopharynx, it goes out of the nose. So you have the entire air is going into the lungs. That's how it has to be done. So once you have done, how many times I said? 10 times per minute. So after 30 compression, again, deep breath and put the thing, ventilate. One more, ventilate. Then continue 30 compression. 30 times compression. Then again, put the mouth to mouth, and if you have readily available ambu bag, nothing like it. You don't have to put mouth to mouth. But ambu bag, very unlikely you will get on the roadside. Suddenly, if I require even OT itself, ambu bag is to be such. So that is the situation. So you have to do mouth to mouth. In COVID times, we never used to advise doing this thing. But no point because chances are that person is dying for sure. You will also die followed by COVID. So we never used to, unless you are putting in PPE, personal protective equipment. So that used to be section during 2020. You have to put PPE before resuscitation. Now, COVID is not there, you can directly approach the patient, start resuscitating it. Chances are revival is very, very high. If you have put carbon monoxide ETCM monitor also, when you are pressing the heart and are doing well, the ETCM level should be more than 10 millimeters. If you are doing correctly. If it is persistently less than 10 millimeters ETCM, that means you are not doing well. Okay, that means you have to improve the level of compression and doing the technique so that it goes more than 10. And suddenly, if the patient is ROSC, that means return of spontaneous circulation. The patient is, because of sincere effort, patient has started recovering. The ETCU2 level from 10 suddenly goes to 40. Because the ETCU, carbon dioxide which has come out eliminated, is coming back through the circulation back into the lungs and coming out. That is instance that the ETCU monitor and we projected the monitor more than 40. Suddenly here, I'll show you on the graphs. That means return of spontaneous ROSC. Please write the ROSC. The return of spontaneous circulation. That means patient. Pulse will be felt now. If the intra-arterial monitor has been put, then the blood pressure can be monitored. All these things. The patient has revived. Don't start celebrating and leave it. Keep on monitoring it. Post-operative resuscitation or after resuscitation also keep on. Because they have likely preterminal arrhythmia. Now, there is a very important question with all this effort, suppose the patient not getting resuscitated, heart is not coming. Still there is one line of cell ventricular fibrillation still seen. Nothing is improving. That is the time you have to give one drug. Amiodarone. Have you heard of this drug? Amiodarone. The anti-arrhythmic drug. So it works wonders. You have to give 300 milligram bolus dose, followed by 150 milligram. First dose should be 300 milligram, followed by 150. Your amiodarone works very well. God forbid you don't have amiodarone, you can give lignocaine, lidocaine or lignocaine, both are same. The dose of 1.5 milligram per kg. These all are effective. Now, the $1 million question, suppose the child is there for giving electric shock, defibrillation. What is the amount of shock you should give? In adult, if you have an old time, monophasic manual defibrillator, we used to give 300 to 360 joules. Everybody say joules, J-O-U-L-E-S. It is pronounced as joules. J-O-U-L-E-S, joules. That is the upper limit, 300 to 360. That is monophasic current. But nowadays, what you are getting is all biphasic defibrillator. The upper limit is just 200. It starts from 120 to 200 joules. Now, can you give this much joules to even a child? No. For a child, the dose is 2 joules per kg body. Suppose the baby is 20 kg, you have to give 2 into 20, 40 joules. And you can select it. When you see manual, I can show you in OT. Readily, if you don't have to be taught, it's a simple. You can manage all difficult computers as a bacha. Very, very small, very easy. You can easily make out what is, how to select the thing, how to give the thing. Everything is written. It is just small. Still, you have not understood. See a video, YouTube, you will understand how to give it. Okay, how to select 42 and one paddle should be put on the apex and one at the bottom, below the right collarbone. That means clavicle. Okay. Even when the two pads which will be readily available in any automated external, one has to be put just lateral to the left nipple and one just below the right side of the sternum below the right clavicle. Okay, only two parts will be there. And put on the daily, everything will be, somebody will be talking to you literally, loud and clear, what needs to be done, how to be done, what is to be done, everything. Suppose with all these efforts also, patient is not resuscitating, you can give something called vasopressin. Vasopressin works very well. Just give one dose of 40 international units of vasopressin. Okay, vasopressin is normally, synthetic, but it's normally secreted posterior pituitary. I hope that is. Just like antidiuretic hormone. Okay? ADH. So that is how we have to use all these drugs. Normally, with all this effort, with this, normally patient. And if you are lucky, the patient is inside the OT, almost 100% device. Because the intubation is already there, there's nothing to worry. I must have visited countless cardiac and I didn't even bother to tell the patient that he had a cardiac because he left cyclist from that had a cardiac disease. We easily revive the patient because everything is already intubated, oxygen is there, intubated, everything is there. We do resuscitation, patient revives. Nothing happens. But outside for everything we have to literally search, locate somebody is there or not. How many people will search, whether the drug is there or not. Nothing is available. Nothing will be of use. So those problems will be there in the outside. But once in the operation theatre, when everything is around, you can 100 to 200%. 200. So there is no countless MS. There is no. Always remember, don't start doing CPR without seeing the pulse because you may have damage. See the pulse, resuscitate only when, if a person is having vasovagal shock, what happens? The blood keeps on flowing in the veins have got one side valve going towards the heart side valve. Going toward the blood, going toward the heart side valve is there. So, if a person keeps on standing, the blood keeps on pulling down into the legs, and the amount of venous return is lessened. So, cardiac output goes down. So, adequate blood is not going to the brain. So, patient won't have ischemia. Like encephalopathy, that is the word I was forgetting. Hypoxic encephalopathy. I was forgetting one word now. The hypoxia has been prolonged, you get brain and damage, ischemia, that is hypoxic encephalopathy. Please write down. There is no point creating hypoxic encephalopathy and then saving the patient. Saving the patient after hypoxic encephalopathy, the patient will be alive but ventilation is some no use. So that is. So you have to give as early as possible. And how you have to do. Now, you have done all these things. Still, there may be possibility of any eventuality. Keep on monitoring what best can be done. After that, after admission, also keep on monitoring, seeing whether recurrence of arrhythmia that can be highly due to anti-arrhythmic drugs. Because after things, arrhythmias are very, very high. So you keep on monitoring. That's how we can save the patient. After saving the patient, as I told you, next 3 days is the critical period. There can be sudden arrhythmias and patient may die. Here, patient survive. You are celebrating. Okay, just Manaran. But after 2 days, what will happen? Patient suddenly you get to message patient suddenly have arrhythmias and die. Why nobody has monitored the patient? That's very important. And when you are ventilating with the face mask, it has the oxygen thing also. Keep on ventilating. I have seen, I hope you have seen the sample source of oxygen. Keep on ventilating at the rate of 10 breaths per minute. Okay? Wish you all the best. Whenever you meet the thing, this is how you can